Hello, in this video we will discuss about some of the most common treatment modalities you can use in general dental practice to treat patients with temporomandibular joint disorders. We will discuss about some of the most common temporomandibular joint disorders and how to treat them in general dental practice. However, before we start discussing about the treatment modalities, you need to understand the limitations we have in general dental practice. And hence you need to always have a referral system in place if you need for those patients who may not be treated by you. So before you start any treatment for any disease, really, you need to make sure you can diagnose the disease properly. So let's recap what we discussed in examination video. The 7 keys or 7 elements you can use to separate intracapsular disease, which is associated with the temporomandibular joint, with muscle disorders. So let's look at the history. As we know that with intracapsular joint disorder, there is usually history of trauma, and from then on, the pain gets either worse or it starts from that after. However, when it comes to muscle disorder, the pain is quite fluctuating. It goes up and down along with the stress levels. When you look at the mandibular restrictions, when you have intracapsular disorder where the capsule has been unable to reduce, you see the mandibular opening limited between 25 to 30 millimeter, and you have hard end feel. Whereas with the muscle disorder, the mandibular opening could be less restricted from any time onwards. It could be 10 millimeter, 15, 20, 25. So there is no certain limit to when it stops opening, but you get a soft end feeling. You get mandibular interferences, which means that in intracapsular disorder, the jaw deflects towards the affected side when protrusion, whereas when you have muscle disorder, during protrusion, there is no deflection seen. You see acute malocclusion with both diseases. However, with intracapsular diseases, you see acute malocclusion which is strongly associated with trauma and patient can pinpoint when it started. Whereas with muscle disorder, if the inferior lateral pterygoid muscle is involved, you see open bite on the same side of the jaw, whereas the pressure on the opposite side of the jaw. Whereas if the elevator muscles are involved, then patient comes with a complaint saying that my bite doesn't feel right and you can't really see what's the issue. And this is usually associated with muscle pain, which starts usually from protective co-contraction leading to myalgia and further on. The 5th main important point is loading of the joint, and this is something I tend to check all the time. It's very easy to check with the leaf gauge, which we'll discuss later on. But once you put a leaf gauge on, and if you're trying to load the joint in CR, which is apparently musculoskeletally stable position, and if jaw joint is painful, then most of the time it is intracapsular disorder. However, if the joint is not painful, then usually it's a muscle pain. If you're trying to put a wooden tongue on the same side of the affected side, and if you ask patient to bite, if the pain is on the same side and it gets worse, then it's usually muscle pain, because usually you're distracting the TMJ from the socket, and if it's intracapsular pain, it should get better. So, and the 7th is when you give direct injection. If the pain is gone, then it's usually intracapsular. If the pain's not gone, then it's probably considered as a muscle pain. So these are the 7 key elements you could use to differentiate between intracapsular and muscle disorders. So let's look at the masticatory muscle disorder first. As we know that this muscle disorder is a cyclic muscle pain, which is very, very common, which means that it may have triggered by something else, but then the cycle begins, and even though the the factor which has probably triggered the pain is eliminated, but the pain continues until you break that cycle. And that's how it works. So our aim is usually to decrease the sensory input which is going towards the CNS system by using some or the other means, either appliance or self-regulation or eliminating of the etiology to the CNS, so that the cycle is broken. So what is the immediate treatment in these cases? So the first thing you can do is remove any etiological factor. As we discussed in previous video, that if the crown is high, treat the high crown. If there is a dry socket, treat the dry socket. If there is anything you can do to eliminate that factor, you should do that. However, there are other factors such as emotional stress. You need to make the patient aware, but you can't personally eliminate that. In some of the cases, giving patient analgesics to reduce the pain helps them in breaking that cycle. And once the cycle is broken, you can get in there and help patient much better. Because once patient's in pain, it's very difficult to think wisely because they are in pain. So you need to look everything, all the opportunities to get them out of pain. So what you can do to help patient as a patient education-wise. So I tend to tell patient and inform them how to manage these kind of conditions by themselves and give them control. Because sometimes, with some patients, being not in control makes it worse. So you give them control, give them some physical self-regulation, such as how to avoid grinding. So if they catch themselves clenching, just ask them to physically move their jaw apart, maybe breathe through their mouth or breathe out with the mouth open, with the lips gently closed, and that will help them breaking that cycle and relaxing muscles. You can advise them to do painless restricted jaw movement, and movement is usually advised unless there is a centrally mediated myalgia present, where you don't really want to create any more pain or more movement to the jaw. But in any case, if you're doing any movement, if patient's getting pain, you need to ask patient to stop doing that, because otherwise it will contribute to that cycle and the pain cycle will not stop. So it has to be painless, whatever the patient do. And that's why I advise patient to have a softer diet, chew softly, or if they're eating apple, cut them and have small chunks and eat in smaller pieces. So these things help. Reduce non-functional tooth contact by making patient aware of clenching. So this is something very first thing I ask patient, that are you aware that you're clenching your teeth? So I don't ask patient that do you clench your teeth or do you grind your teeth, because most of the time patient will come back and say no, I don't clench or grind my teeth. However, you can see the signs of them clenching and grinding. So I tell them that you clench your teeth. I know that, but are you aware of it? And saying in this manner, patient will be able to check again when they go back home, coming weeks, and be able to monitor themselves. And when they catch him themselves, they will be able to stop doing it. It is very hard and it requires patient cooperation, but it does help. And lastly, you need to make patient aware the relationship between stress and muscle pain. Although you cannot do anything about that stress maybe, but you need to make them aware, because you don't want to provide treatment to patient and give them hope that you will be able to eliminate all their problems, which is not true. So you need to make sure that the patient is aware that when you're treating them, you are treating them from your side, but you will need a lot of help from their side. So if the treatment doesn't work, patient is aware that there is an element of stress involved in this, and that is out of your control. So what are the ongoing treatment you can do? So the first treatment you can suggest is a physical therapy, which involves passive muscle stretching without inflicting any pain. Now, how can you do that without inflicting pain? You can use heat, you can use cold, you can use spray, you can use analgesics. Now, there is no such real evidence between heat and cold, that whichever works better. Sometimes for some people heat works better, sometimes some people cold works better. Ask patient to try both and see whatever works. I personally do not use anesthesia because usually heat and cold helps to giving them some physical exercise. You can advise them to massage deep, usually do a deep massage around the area, or also advise them into mindfulness and meditation, which is really helps in reducing the stress and giving them control back. Obviously, you can give them occlusal appliance such as stabilization splint. One of the exceptions is protective co-contraction. As we know from the previous video, that it's a very transient issue. In protective co-contraction, what you need to do is you need to eliminate the reason why it happens. So if it's a high crown, high filling, you need to make sure you try and eliminate that as soon as possible so the cycle does not start. And it's quite soon, so by eliminating the factor, you should be able to help. The other area you don't need it is when patient has a trauma, which we'll discuss in temporomandibular joint disorder. You don't need appliance because you know why patients having issues because of the trauma. And once it heals, it should get better, theoretically. So consider, after doing all this, if patient's not improved, then you need to consider misdiagnosis or management of sleep disorder, because sleep disorders are something in general dental practice we do not think of, but can be a source of deep pain input. And this is something you cannot treat. You need some other help. However, for any referral to the sleep clinics, you need to be trained enough to diagnose the issue before you do this referral. So this is some general common treatment modalities you can use in general dental practice to treat muscle disorders. Now, what about the temporomandibular joint disorders? So let's look at the two main temporomandibular joint disorders: disc displacement with reduction and without reduction. So let's look at the first, disc displacement with reduction. So what is our goal in this case? As you know, when there is a disc displacement with reduction, what happens is the disc is reducing back, producing a clicking sound, which could be single click or double click. When patients having this clicking, per se, it's not a disease. And there are numerous studies shows that even after all the treatment, 42% or 43% of the cases are still left with some sort of a clicking sound. So eliminating clicking is not our goal. However, if patient comes with pain or discomfort, eliminating pain and discomfort should be our goal. So if patient comes with a clicking and there is no pain, then I tend not to treat those patients, because you cannot be certain that you will be able to treat those patients and eliminate clicks. So the way you treat patients with the pain or discomfort is by trying to recapture that disc condyle assembly and trying to make them back to its normal position. Again, patient education is very, very important. You need to make patient aware not to open their jaw too wide, or not to chew food, not to inflict pain. Same thing with the soft diet, smaller bite, and slower chewing. Reduce non-functional tooth contact will also help by doing some meditation, mindfulness, and also trying to keep their teeth apart during the daytime, and be aware of it. So what are the ongoing treatment? So one of the ongoing treatment is physical therapy, however, which is passive jaw movement. However, no active jaw movement should be recommended in these cases, because it's intracapsular. Moving the jaw is not going to help patient to recover. Occlusal appliance such as stabilization splint and anterior positioning splint helps. Anterior positioning splint was invented in 1970s, or really made it popular in 1970s, should I say, where the jaw was moved forward, appliance was fabricated, so the capsule is not loaded, or the jaw joint is not loaded, and it gives time to recoup that jaw joint. However, that appliance has been given very bad publicity because it started giving posterior open bite for prolonged use. And that's why I usually recommend to use that appliance for only 6 to 8 weeks, followed by stabilization splint, and only to be used at night time, not for full during daytime. If patient must use during daytime, but then keep it limited to 1 to 2 weeks and review the patient back. With regards to if patients, you have managed to recapture the disc, then you can give patients stabilization appliance, and you should be able to help those patients. Analgesics is helpful if pain is involved. Now, what about the disc displacement without reduction, where the disc is not going back? So again, our goal is still to recapture that disc condyle assembly. However, in this case, it may be difficult if it's not going back by itself. So our immediate treatment is to do manual manipulation, which works surprisingly well if the disorder is acute within 5 to 7 days time, where the inflammation hasn't kicked in and the cyclic pain hasn't kicked in. So the sooner you do, better it is, and more result you get with that. The other issue with manual manipulation is severe pain. You may have to use some injections, anesthetics, for patient to get out of pain before you try and manipulate their jaw, but it is very painful when patient has this issue. So with regards to immediate treatment, you have manual manipulation. The first time when you're doing this, or when patient comes to you, the first thing you should do to patient is ask patient themselves to try and manipulate the jaw without your interferences, and try and recapture the disc. The way I advise patient is to open their mouth as wide as they can on the move the jaw contralateral side first. So if the jaw, the right and left hand side is affected, I'll ask patient to move jaw on the right hand side as much as you can, and then open their mouth and try and recapture the disc this way. Now, if they're opening maximally and if the disc is still, they're unable to capture the disc, try and do it a few times. Now, even after doing this, it's not possible to recapture the disc. Then what you can do is use your thumb and place it on the second molar area of the affected side, and try and press it down, and try and use your forefingers on the inferior border anterior to your thumb, and try and move it up. So then you're trying to recapture the disc, at the same time trying to open patient's mouth. And this manual manipulation helps, as I said, when the disorder is relatively early or within 5 to 7 days time. However, if it still kicks in and you cannot do that, what else can you do? You can ask patient to avoid inflicting pain by opening wide or for exercise of jaw related. Ask patient to use soft diet. Application of cold or heat can also help in reducing pain, which is secondary to the temporomandibular joint disorders. In ongoing treatment, occlusal appliance such as stabilization splint helps. However, if you are unable to reduce the disc, then anterior positioning appliance is actually contraindicated, because you can cause more pain by giving patient anterior positioning appliance. Regarding stabilization appliance, the study shows that it gives patient much more comfort, and over 2 years time, patient end up having a little bit more normal jaw movement with this type of appliances. Now, surgical treatment such as pumping of the jaw, arthrocentesis, arthroscopy, arthrotomy, or disectomy is also is treatment modality. However, these are very extreme, and one should carefully assess this before doing this treatment. However, as I said, you won't be doing this kind of treatment in general dental practice. This is more of a patient-based discussion. If patients comes to you, you should be aware of how the treatment modality might go. So to summarize, once we did immediate treatments and done patient education, in treatment there are two main modalities you can use. You have in muscle disorder, most of the time I end up giving patient a stabilization appliance, which is such as a Michigan splint. Stabilization appliance or Michigan splint in my case works really well as far as it's adjusted properly and is made properly, and this we will go through in our next series of videos in detail, because I think it has not just one use, it has multiple use, and you will know why. However, in temporomandibular joint disorder, apart from stabilization splint, you can use anterior positioning appliance, as I said before in the discussion. So really, you need to learn about, in general dental practice, stabilization appliance and anterior positioning appliance. Now I'm making it really simple. There are lots of other appliances available which we will go through in our next video. However, for temporomandibular joint disorder, in my clinical practice, these two appliances works really well. For any reason, if I have done these, patient have used these two appliances and I haven't seen any results, I'm very quick and referring patient to a specialist who is specializing in TMD diseases, because I'm not a TMD specialist and it does require complex treatment planning or diagnosing the disease in order to treat these diseases. However, I would say most of the time 80% of the patients who show some sign of pain or temporomandibular diseases gets help by these two appliances. So you may ask, what happens, when how does this stabilization splint work? So there are numerous ways it works. It works sometimes because you're changing the occlusion, and occlusion is one of the reasons why patients getting pain. It works because you're changing the condylar position into more musculoskeletally stable position, because occlusion, there is such a big slide, maybe patients getting this pain because it's not musculoskeletally stable position, because maybe you changed OBD and patients now feeling better because of the change of OBD. So these three are related with teeth. Now, there are other factors which is such as changes in cognitive awareness. So patients more aware of their disease, and that's why they're trying to do more precautions, and that's why it's helping. You're altering sensory input via CNS because you're changing something and giving patient the CNS system a little bit change, and that's why it's reducing the pain. You're changing natural musculoskeletal recovery. So because you're giving that joint or muscle to recover, it's generally just recovering and feeling better. You then have a placebo effect because maybe you believe in treatment, or patient trusts you, or patient believes in treatment, what you're providing, and then there is a very good placebo effect because of that. Or it's just, there is a cyclic event, as you know, sometimes pain get worse, better, worse, better, and you might pick up the patient when it's in the peak of its pain, and whatever you do is just going to get better from there. So it's just like a placebo effect, but it's true effect. So let's say patient comes to you with pain. You said, okay, it's a muscle pain, let's say, and you have given patient stabilization splint. Patient comes back to you. You need to ask yourself, you need to tell a patient comes back to you and say, oh, doc, I don't have any pain. Thank you very much for helping me. So what do we do next? What you can do next is ask patient to stop using the splint and see if the pain comes back. If the pain comes back, then most of the time the occlusion has got some play in it. So occlusion has got some factor because of the occlusion is giving you patient pain. So you need to consider what can you do to adapt the patient. However, it's very rarely in my practice I would do full mouth reconstruction just because patient's in pain. If patient comes back with pain, then I've established that, okay, occlusion could be one of the reasons why it's painful. And if patient already needs full mouth reconstruction, then I'll go ahead and do full mouth reconstruction. It will help me diagnosing that by doing full mouth reconstruction, by making CR equals CO, it will help me reducing patient's pain. However, I do not guarantee patient this, and I tend to try and do occlusal equilibration first and then try and manage these cases like that. Or you can do maintenance. You can just give patient a splint and just ask them to carry on wearing it because there is no pain. If patient got intact dentition, I personally do not tend to chop their teeth down and do full mouth reconstruction. If patient's pain is gone because they are wearing splint, I just ask them to keep wearing splint. It's a removable full mouth reconstructions. Or on the other side, as I said, you can do occlusal equilibration, restorative treatment using fixed or removable appliances, orthognathic surgery, or orthodontic treatment. On the other hand, if patient comes back and the pain's not there, then I tend to say to patient, okay, you keep the splint. If pain comes back again, use for a brief period of time and then stop, and then see whether pain is coming back or not. Because these patients are usually not related to occlusal factor. The pain is not related due to occlusal factor. It could be stress, it could be something else which you don't know of. So there are multiple factors associated with this, but this is how I decide whether to do some intervention or not. And most of the time, if it's not needed, because if the teeth are not being need to restore, I tend to just ask patient to keep wearing splint, even if there is occlusal issues which may need very extensive treatment, which means may be damaging healthy tooth tissue. And this is my personal opinion. I know there are different variation of the opinions available, where some people will be very extreme and start doing occlusal equilibration and full mouth reconstruction, whereas as I said, I choose to try and avoid it. However, if patient needs a full mouth reconstruction, I'm more than happy to provide patient, because now I know that occlusion is one of the main reasons why they're getting pain. So I hope this series of videos in temporomandibular joint disorders were helpful. It was aimed for general dental practitioners to deal with common issues which you can come across in general dental practice. In next series of videos, we'll discuss in detail about occlusal splints such as Michigan splint and how we can use that in doing various modalities of treatment, including treating TMD cases.